All right. Very warm welcome. First of all, of course, good morning and a very warm welcome to all of you. Those who are joining in person, and we have many participants online. So welcome to this first hybrid seminar of the year 2025, organized by the Center for Transportation and Logistics at IIM Ahmedabad. It's my pleasure to have with us today Professor Chandra Bhatt. Thank you so much for coming. Professor Chandra Bhatt is going to speak about his study on telemedicine adoption that has implications for healthcare, telecommunication to transportation planning. A brief introduction about Professor Chandra Bhatt, although he needs no introduction. He is the Joe J. King Endowed Chair Professor in Engineering at the University of Texas at Austin. And he's also currently serving as the director of the US Department of Transportation's National University Transportation Center that focuses on travel behavior and demand. He's a distinguished teaching professor at the university as well, and he holds appointments at the Department of Civil, Architectural, and Environmental Engineering, as well as the Department of Economics. Professor Bhatt is a pioneer in the formulation and the use of statistical and econometric methods to analyze choice making, particularly choice behavior in the transportation and urban planning contexts. Among his many awards and accolades, most recently in 2024, he was awarded the W.N. Carey Jr. Distinguished Service Award, which is a big deal, for his leadership and distinguished service to the transportation industry, academia, as well as practice. The honor was by the Transportation Research Board of the National Academies of Science, Education, Engineering, and Medicine. Professor Bhatt is ranked among the top 3 scientists globally in transport and logistics, and with about 45,000 citations. He's the number 1 top scholar in travel behavior as well as transportation safety and other domains of transportation. This is his 3rd visit to IMA. He has visited us in 2019 and 2020, and after about 5 years, Professor Bhatt is part of our CTL advisory board, and he has been with us when we set up the center from its very inception and helped us in growing over the past several years. Professor Bhatt has mentored many PhD students, all of whom have become leading academics or practitioners within the transportation field. Currently, Professor Bhatt is the chief editor of the Transportation Research Part B journal, again, an extremely prestigious journal in transportation. So today, he's going to talk about his study on identifying the determinants of telemedicine use that has wide-ranging implications and applications across healthcare, telecommunication, as well as transportation planning. So over to you, Professor Bhatt. You can just run the seminar the way you want.
Thank you. Appreciate it. Namaskar. I was getting a little worried that he's going to take all the time window of my talk in introducing me. But it's a pleasure to be here. As Sandeep mentioned, this is my 3rd time at IMA. And what I'm going to do, you said I'm supposed to be in a certain frame. I'm just going to be moving around, and the voice should be sufficient for those who are online. So what I want to talk about, hi Preeta, good to see you, is about telemedicine adoption. But first, I do want to talk a little bit about our center. We called it the TBD Center, and it was by design. Travel behavior and demand, yes, but also we called it TBD because of the uncertainty that lies in what needs to be done in this area of research. So it's TBD. And when we introduce our center as TBD, the first thing that I get questioned is, why TBD? But the idea is to really show that this field has got so much of uncertainty as we move forward, and we have to be able to address that even as we come up with mathematical ways of thinking about and modeling human behavior. So these are all the institutions, the universities involved in the TBD Center, which is funded by the US Department of Transportation, and it's the national center. This particular research is with one of my current PhD students. She is planning to graduate in about 6 months, and I'm pleased to say that this particular work just got accepted for publication and might have just come out in transportation research. So we all know what virtual participation is. Certainly was in existence even before the pandemic, but was spurred on considerably by the pandemic. There's been a whole lot of literature on telework in the context of virtual participation. And much of this has focused on, do people go into the office or do they work from home? But at least in the United States, a third workplace location came into being, which is the third workplace. So going and working in cafes, or just traveling, going to the beach and being able to work from the beach. So this third workplace didn't get too much attention until recently, but there is some attention. And yes, I have to give a shout out to some of my graduate students. Katie Asmussen, she's done some excellent work in this area of telework, including the third workplace recently, and we have quite a few papers with her. And then there's been a good bit of work in the area of in-person shopping. That is, how do people, do they adopt, and how frequently, and how does that impact physical participation, in-person participation for purchase of groceries, for purchase of other electronic items, and more generally shopping. So there's been a little bit of work in that area, and it was that even before the pandemic. Again, not much differentiation between non-grocery and grocery, because there was very little of grocery online shopping before the pandemic in the United States, but that really increased. So now we are able to distinguish between the two, and there have been some studies in that area as I'm listing out over there. And then in-person eat out, that's been very interesting too. So how has virtual participation impacted in-person eat out? For example, am I eating out today, or am I ordering in? And if I order in, am I collecting it curbside, or am I having it delivered to my home? So all of these are important from a travel standpoint, because whether it's shopping or whether it is eat out or whether it's work, I might not be going out because of my virtual participation, but at least in the context of shopping and eat out, that's a delivery that comes inside, right? So that travel has to be accounted for. And so how do all of these things come together has been fascinating and interesting. If I had to summarize the work so far, the idea that virtual participation will reduce travel, that is not panning out, if I had to summarize, because there is not just substitution that's happening, there's also a lot of complementarity that's happening. So a person looks at something online but wants to have a touch and feel of it, so goes out to the shop, touches and feels it, and then comes back home and does some additional comparison shopping. So there is a good bit of complementarity in that. And that's one reason. The other reason why there is complementarity is I'm saving time through virtual participation, and that now expands my time availability to pursue activities that I didn't pursue before. So there's been a whole lot of work in that area. Again, a good bit of work from our team at UT Austin, but from elsewhere too. And in short, again, as I said, it doesn't seem like as though virtual participation is going to be some kind of a panacea and it's going to take care of all our traffic ills. It doesn't seem like we can bank on that. Now, what we want to focus on in this paper is medical visits. As far as we know, this is the first study that focuses on land use, transportation, and telemedicine. We wanted to know what's happening with telemedicine that may be the same, may be different from other types of teleactivities. So the focus here is on in-person medical visits. Now, all of this kind of, I would say, juxtaposition of in-person and virtual, it has implications for transportation, of course, but also land use. We'll talk about that in just a bit. And health in the context of telemedicine. And of course, the larger economy. E-commerce seems to be everywhere, so it has an impact on economy. And one of the things that we went into this study was trying to understand who are the people who are adopting telemedicine. Okay? But as importantly, are there inequities in accessing telemedicine? And are the inequities that already are there in terms of in-person health consultations, is that being further increased because of telemedicine? Is it helping reduce these inequities, or is this further exacerbating existing inequities? That's something that we really wanted to focus on. Anyway, just to show you in terms of telemedicine in the United States, I'm sorry, all of the data here I'm showing is from the United States. I should have made some effort, I think, to look at what's happening in India. But before the pandemic, telemedicine visits were 1% or so of the total outpatient visits. And you can see that in this graph. And of course, come March 20th, immediately went up for obvious reasons, lockdowns and all that. And since then, there's been a tapering off. As you can see over here, there was a second wave. This is, I think, what's it called? December 20th. It was called a certain variant, which I'm not getting the name of. And again, you can see a small increase over there. And so there'll be some small spurts of an increase. Now, it's been stabilizing today anywhere from about 10% to 20%, depending upon the area of the United States. But what are some of the drivers of the rapid increase in telemedicine? Of course, spurred again by COVID, but a number of physicians using telemedicine increased substantially. Regulations were relaxed. Earlier on, insurance is a huge area where the United States, I think, can learn from many other countries of the world. Okay, I like to say education and health. Those are the two areas where, oh my goodness, I think we really need to do way better than where we are. But insurance relaxed regulations and allowed for these kinds of telemedicine consultations. And of course, the growth of platforms. So that was the increase in supply, and related to that was the increase in demand. Flexible regulations allowed for use of platforms, and again, insurance companies incentivizing telemedicine utilization. Before the pandemic, many of these insurance companies were very wary of telemedicine because is this going to kill them? Mental health issues, etc. Very wary. But then post-pandemic, as soon as the pandemic hit, again to their benefit, they were looking out for themselves, and they realized they had to incentivize telemedicine, otherwise they would get out of business, right? So insurance companies started incentivizing telemedicine utilization. I hope there are no insurance company folks over here. I have a certain mindset, and the way I come from is pretty strong sometimes. And reasonable level of patient satisfaction also helped boost telehealth. Now, as I said earlier, this adoption or not has implications beyond healthcare, and we'll talk about that a little bit more. So what did we do? We utilized a relatively cool econometric model for analyzing telemedicine adoption longitudinally. We also looked at the evolution patterns before and after. Are some individuals who were using it before now not using it as much, or are those who are not using it earlier now using it in the droves. We are looking at those kinds of shifts. And we wanted to quantify the causal effect of the pandemic on telemedicine. And also, most importantly, analyze individuals' perspective on reasons for adopting or not adopting telemedicine. So the data, we got it from what is called a COVID Future Panel Survey. So you can see the timeline over here. The first wave of the data was collected between April 2020, this is when the pandemic was declared, to May 2021. And in this wave, the question that was asked in terms of telemedicine was, did you ever use telemedicine before the pandemic? Yes, no. It was a simple yes, no question. And the reason why we kept it simple was that telemedicine was not prevalent before the pandemic. And the yes, no helps in terms of recall. It's much easier. Any recall biases are much lesser when it's a simple yes, no question. In wave 2, we asked the question. It was between May 2021 and October 2021. We asked a question. By the way, this was a time when vaccinations started coming quite a bit and became commonplace in the United States. So between May 2021 and October 2021, the question that was asked is, during the pandemic, did you use telemedicine? One or more times. Again, yes or no. Okay. And the last was wave 3, between October 2021 and November 2021, which was really looking forward. Do you expect to continue to use telemedicine once there is some semblance of normalcy that might return? Okay. Now, those 3 yes-no questions were used as indicators of telemedicine adoption. Now, these are all different metrics of adoption. One is based on memory, past behavior. The second is actual revealed behavior. And the third is expectation. Okay. We just decided to call all of these 3 as telemedicine adoption. Okay. We can be much more careful in terms of saying one is self-reported, one is recall, one is futuristic expectations. Just for keeping things simple, we just called it all telemedicine adoption. And the first one was what we call before. This was during. And the last one, the futuristic expectation, was after COVID telemedicine adoption. So, and this is what we asked. Just as I indicated, the 3 questions that form the basis for adoption. Now, why are we asking all the 3 questions? From an econometric standpoint, we want to be sure that there might be some unobserved factors that are not captured that we want to control for across the 3 waves, so that we can perhaps better attribute any changes between the before and after to individual characteristics as opposed to that we collect as opposed to unobserved characteristics. So very brief descriptive statistics. Before COVID, you can see that about 11.5% said yes, they had used telemedicine at some point before the pandemic. A majority obviously said no. And after COVID adoption, you can see that it increased to 35.8%, with still a reasonable majority saying, they don't expect to use telemedicine after COVID. And not surprisingly, you see the yes and yes and the no and no. That diagonal is quite substantial. And this gives you immediately a sense of there could be correlation, unobserved factors, individual factors that make a person more likely or not likely across different spans of time. But the important point is there has been an increase in telemedicine adoption post-pandemic. So we also asked for reasons for adopting telemedicine. Now, these reasons were asked only of those who said they had adopted telemedicine in the 3rd wave. That is to say, do you expect to use telemedicine in some near future after normalcy is returned? So only those who answered yes to that were asked what might be some of the reasons why you would continue or you would adopt telemedicine. And Convenience. Convenience is the most invoked attribute, but less wait time, no risk of getting sick, comfort of home. All of these are also up there in terms of reasons. Now, these are all yes, no. So we had questions. All of these were different questions, and you just had to tick yes, no. Reasons for adopting. Yes, this important to me, this important to me. So it was yes and no. Okay. And for those who said they would not be adopting telemedicine in the post-COVID, why would you not be adopting telemedicine? And again, you can see the percentages over there. In-person test procedures, in-person is more convenient. Some of these reasons which are not surprising. These are just descriptive statistics. Before the pandemic, there have been some studies that have looked at things in this form, that is aggregate descriptive statistics. But what we wanted to do is, who are the people who choose specific reasons? Okay? And who are the people who choose specific reasons for not adopting? Who are these? Because there's going to be heterogeneity across individuals. That's something that we didn't see being done earlier. So in terms of the modeling framework, we have a whole lot of exogenous variables: individual, household, employment, personal traits, COVID perceptions, and built environment attributes. The built environment attributes were pretty aggregate. As I recall, it was, would you characterize your residential neighborhood as urban, suburban, rural? But we also included the number of healthcare healthcare locations in your residential neighborhood. We were able to get that using additional sources of data. So how many, and it was just sum of all possible locations where you could get healthcare consulting or advice in your neighborhood. We just summed all of those up as one built environment attribute. And we had the yes, no across the 3 periods. We had those responses. And these indicate that there could be unobserved correlations, individual characteristics that we did not observe, that we need to control for. And as I said earlier, in the 3rd wave alone, if a person said yes, what are the motivators for tele-adoption? And if a person said no, what are the barriers for telemedicine non-adoption? Now, the problem here is, from an econometric standpoint, we need to also control for the fact that you could have sample selection. So only people who said yes answered the motivation reasons, and only those who said no responded to the barriers. Now, here we have the situation where a person, let's say, who's very introverted, right? A person who's very introverted might be more likely to use tele-adoption, so answers yes, but also might invoke privacy as the main reason, as the motivation, okay? Now, if I don't observe this introverted nature, then that could be a correlation between adoption and the motivating reason for adoption. What we wanted to do was, we wanted to be able to extend these motivators and barriers to the entire population at large, regardless of whether they would adopt or would not adopt. And if you want to do that expansion, we need to take care of some of this sample selection that happens because people answered appropriately to their response of adoption. I won't go over the methodology anymore over here. It was a fascinating methodology. We had a system of 18 different equations, but we were able to estimate this system, this model system, using some cool methods we developed at UT Austin a few years back. So some general results. Individuals likely to adopt telemedicine before COVID, middle-aged, were more likely than those younger and those older. Now, this could be perhaps because those younger rarely go to the, rarely, in general, do not need much of advice on their health. And so when they need to, they don't mind going in to the doctor's office. And those who are older may prefer in-person visits because of various tests and procedures that they need to be done in person. Now, students, we have always found, are much more savvy from a digital standpoint, so they were more likely to adopt. Low vehicle households, not surprising, frequent teleworkers, households with children. And what we will see is that households with children, before and after, they were more likely to adopt telemedicine. Okay, that's remained constant. There was no change between the before and after for households with children. And of course, the tech savvy. So now, what happens in terms of adoption after COVID? Middle-aged, no more, can be distinguished from the younger individuals in terms of telemedicine adoption after the pandemic. And this potentially could be because the younger folks came to realize telemedicine adoption is anyway convenient, and even for their few visits, they started adopting telemedicine much more. Low vehicle households continue. There's accessibility considerations. Frequent teleworkers, maybe these are the very digitally savvy ones. They are very comfortable with any kind of tele. And households with children, as I mentioned, continue to use telemedicine. Some of the new factors, though, as I said, younger relative to their pre-COVID, the younger ones are increasing, which is why there is no more of a differentiation between the middle and younger individuals after COVID. Perceive COVID as a risk to society. So that intuitive, if I perceive that risk to be higher, then I'm more likely to use telemedicine. I don't want to be exposed. So why and why not? If you look at the telemedicine facilitators, and now because of the way we took care of sample selection, these are for the entire population. I can extend this to the entire population. So what are the telemedicine facilitators? In terms of addressing difficult access issues, again, not surprising, zero vehicle households invoke this as one of the main reasons for adopting telemedicine. Unemployed, household with children, okay, they address difficult access issues. This could be perhaps because of the frequency with which you want to have medical visits and consulting. And so, it might be perceived, going to the doctor might be perceived as difficult access, and that's why many of these people seem to use telemedicine, adopt telemedicine. Low income, is it because of driving expenses or limited public transportation options? It could be, okay. It's quite well known that in low income and minority neighborhoods, access to any form of transportation is worse than in other neighborhoods. And not surprisingly, it is also so in terms of the number of physicians and their offices that might be reachable easily. Women, they invoke access issues as an important reason to adopt telemedicine. Again, this might also be tied to the dynamics of, even if you have vehicles in the household, who seems to have first say over those vehicles. So that could perhaps be leading into women perceiving difficult access issues as a reason for telemedicine. Now, telemedicine is convenient. Women, interestingly, also say that telemedicine is convenient, which goes with their perception that in-person visits are difficult to access. Improved privacy. Those who are employed invoke that. The older individuals, They seem to think that telemedicine offers more privacy, but we'll see something different happening elsewhere. Less wait time, that's invoked by particularly high income individuals and younger individuals. And this could be a younger, older generation, time related considerations, attention span, comfort of home. Frequent teleworkers, they invoke comfort of home as the main facilitator for telemedicine. Okay. Let's look also at risk of sickness. Not surprising, older people are much more likely to invoke that as a reason for telemedicine. And women also invoke risk of sickness much more so than their male counterparts as a reason for telemedicine. This is interesting. Why might this be so? In general, studies in the health field have shown that women tend to be more health conscious than men. Okay. Why might that be? That could be for a variety of reasons. That could be because they see themselves as the rocks of the home. It could be because they are much more concerned, society-driven, of body image-related issues. Surprisingly, one of the things that I try to convey to my two daughters, and it's not going to be successful, I'm sure, is should they decide to have a partner, I have just asked two things of them, which is not going to pan out because it's at the end their choice. One is the partner should retain our last name. And the second is the partner should be a vegetarian. And my daughters very appropriately respond back, "You're so dumb, Dad. You're absolutely dumb." Now, on the first one, I think they might be inclined toward it, retaining the last name. I dropped an ask that I had that the partner should take our last name. I don't know if that might go anywhere. But the second one, they shot it right through. And there's a reason for it. When you look at a pool of vegetarians, women dominate that pool way more than men. Okay. And you might start thinking, why is this so? Now, again, there's literature that suggests that women tend to be more altruistic in general toward fellow living creatures, and that might be one trigger. But certainly, the issue of health is another trigger. Okay. So this notion of wanting to be healthy among women, that has been well established in the past. And so it's not surprising that they would invoke risk of sickness as one of the reasons for telemedicine adoption. So what are the deterrents? When you look at the deterrents, men generally feel like telemedicine is not as good as in-person visits. Okay, I'm not sure why this might be so, but it seems to come out quite clearly. Households with children, and this could be, they have concerns that telemedicine cannot meet healthcare needs of children who require attention to non-verbal cues. Children find it more difficult to verbalize what is going on with them. And in telemedicine, recipient on the other end doesn't quite get what the child wants to say. And physical examination. So that might be why they look at telemedicine as being worse than in-person. Older people, they like in-person visits because of the tests and procedures that they have to, they might have to undergo. Reduced privacy. People who work from the office suggest that one of the deterrents to telemedicine is I cringe when I try to take a medical call when I'm surrounded by my coworkers. I don't want that. Inconvenient, again, you have a whole bunch of individuals, non-teleworkers, children, older individuals, etc., who invoke that. Non-tech savvy, I'm not very tech savvy. Obviously, older people generally feel they're not as tech savvy, and so that might be a deterrent. And low income because they might not have easy broadband access. I won't go over all of these correlations that we control for. These are the unobserved factors, just to be sure that what we are ascribing to observed individual characteristics effects are potentially more accurate after taking account of associations. But the one thing, not surprising, is that you have positive correlations in the telemedicine adoption across the different periods, as we would expect. Okay. Lots of these. Okay, so some general policy implications. We can categorize it into health equity considerations, telemedicine integration, and transportation. Let's start with health equity. Women seem to perceive telemedicine as a good alternative to in-person visits, more so than do men. They perceive reduced in-person access, and that's why telemedicine is to them a facilitator, convenience, and they see telemedicine as a way to reduce their sickness risk. So those are all the reasons why women like telemedicine. So one thing that can be done from a policy standpoint, online clinics staffed with specialists in women's and children's health. That might further build on women's general inclination for telemedicine and satisfy the demand for more frequent appointments, particularly among households with children. Okay. Now, households with children, they see advantages in telemedicine because of reduced in-person access, or rather, because of reduced in-person access, they seem to move toward telemedicine, and the more frequent appointments is one more reason why they like telemedicine, but they perceive telemedicine as being lower quality. Okay. Again, this because of perhaps the verbal cues that and the non-verbal cues that might not be picked up by the person on the other end. So for individuals with children, leveraging virtual technologies might help. Hybrid models, maybe there's some kind of a system where you have combinations of in-person and telemedicine visits and collaboration with child development experts. Can we train medical experts to be able to pick up on body language, non-verbal cues of children? Maybe there needs to be more training done along those lines. 50 years or older, they like the improved privacy. They like telemedicine because of reduced sickness risk, but they are not very tech savvy. They're self-reported, and they say that telemedicine is not very convenient. So for these individuals, perhaps there could be partnerships with community organizations to offer digital literacy workshops, providing loaner devices preloaded with telehealth applications. How can we make it easier, more convenient, so that they can take to telemedicine more so? And using loaner health monitoring devices, that could help too. For low income, and this was low income, but also it was minority race. Okay, not that the two of them necessarily go together. I don't want to make that congruence. Okay, but at least in our study, low income separately as a main effect, as well as minorities, that is non-white, separately as a main effect. They generally perceive good quality, reduced in-person access as a reason for telemedicine. They perceived improved privacy, but they found they felt telemedicine is not convenient. They didn't feel they were very tech savvy, and they were much more concerned about data security. So for such individuals, Again, healthcare initiatives can bridge this digital divide because they perceive good quality in telemedicine, but we need to provide much more of access to the internet and bandwidth. And digital literacy initiatives can also help. So in the large scheme of things, telemedicine can effectively bridge accessibility gaps. Now, what about telemedicine integration in the workplace? This is interesting. In-person workers, they found telemedicine, it's not very convenient. That's why they are deterred from using telemedicine, and lack of privacy is another deterrent to using telemedicine. So it's quite possible that one way to deal with it is provide private spaces at a workplace to conduct telemedicine appointments, gives them privacy. If not within the office, set up sites from workplaces, close to workplaces, for the exclusive purpose of telemedicine use. So, reserving a booth type approaches. The last one, also related to what I just talked about in terms of transportation, telemedicine results in a reduced need for physical travel and medical professionals to commute. It's a little bit different from that standpoint from teleshopping. In that teleshopping, I might order something, and while I'm not making the trip out, someone is making the trip in. Okay. Telemedicine is a little bit different from that standpoint. Okay. It has a true potential to reduce the need for travel. And not only that, medical facilities are often located in urban areas, major corridors, and can contribute to localized congestion. So this could be a good approach to reduce traffic congestion. And not only that, it's not just the spatial distribution, but the temporal distribution of trips. We find that trip chaining is pretty common. So if I have a doctor's visit, I tend to chain it with my commute to work or on my return. Okay? And that can lead to an expansion of the peak period congestion window. Okay? So even there, by having more telemedicine, it can prevent the need for, obviate the need for too much of this trip chaining, and can help in terms of transportation from that standpoint too. And there are some opportunities to redirect investments, enhance innovative transportation solutions such as on-demand shuttles. And what about this? Maybe we don't need these huge hospitals that take up so much land use in urban areas. Replace them with a network of mobile clinics stationed close to dense employer sites. It provides privacy. Okay. And the land that becomes available because of the lack of a need for these large hospitals can be reused in many different ways. So from a land use standpoint, that could be substantial benefits. So in terms of travel modeling, we are not considering telemedicine at all in any of our models so far. We don't know still. This is the first study that we are aware of that's starting to explore who is adopting, and we have not really looked at what are some of the travel implications of telemedicine adoption. Okay. Telemedicine, or rather medical trips, in the large scheme of things, might not be a substantial portion of total trips in an urban area, but they're not insignificant either. Okay. So especially because of the spatial concentration, where most hospitals are located in dense urban areas, and the temporal concentration of all of these trips, morning commute or evening commute, that could be some substantial benefits. We don't even collect telemedicine use in our surveys. Did you collect that in your recent survey with Sintra in India, in Mumbai? NHTS, does it collect it? In the United States, NHTS is a National Household Travel Survey, nothing about telemedicine. Okay. Most surveys don't even ask about health trips. Don't distinguish between health trips and shopping trips and all non-work trips. That's it. Okay. We really need to get a better sense of health trips in general and how many of these trips might be obviated because of telemedicine. So future travel surveys, I think it would be good to include information on teleactivities. Many surveys today include information on telework. Okay. A few have started asking the questions, have you ordered anything online in terms of packages, in terms of groceries? Okay. But we haven't seen a transportation-oriented survey that asks any questions about medical trips. Of course, limitations galore, like any other research work. We focus only on adoption rates, not frequency, type of visits. These visits could vary quite a bit based on checkups, illness, specialty, etc. We then distinguish between the type of visits. Yeah, so does not distinguish between consultations for respondents themselves and those for their children. Okay. All that we had was a variable households with children. And the household was asked, did you make any telemedicine visits? Okay. It was not clear whether it was for the child or for the adult. Okay. So that distinction might also become important. Yeah, and an analysis limited to individual adoption, not how multiple household members utilize telemedicine. So that's one more. Now, one last thing, I have about 2-3 minutes to summarize. This is something I've been thinking about. It's much more of a philosophical issue. There have been some fierce debates recently on what is the best way to collect data in general about travel, about our activities, okay, how best to capture. And I wrote this article in 2022. People would say, oh, revealed behavior is the best way, it's the best approach. Stated intentions, there's some good in it. You can ask about intentions that are for travel modes that are not available today or for contexts that are not present today. So they do provide some value, and they are well established from the theory of planned behavior, technology acceptance. You have all of these models. The basic idea that our intentions do correlate reasonably well with our behaviors and our actions in the future, though it's not a perfect correlation. Obviously not a perfect correlation. So a number of people would say, hey, reliability of stated responses may still feel like rocket science. It's not reliable at all. That could be one not so good. But I think that we are, getting caught up, in my mind, in trying to defend what we believe is the best data collection approach, when we really do not know what is the best data collection approach. Okay. So let's strongly encourage the need for a pluralistic approach to obtaining activity travel behavior data than spending time debating on which data collection method is the best. I think we are not, having constructive contributions to the literature, because a good part of the scholarship is focusing on, no, stated intentions data are just worthless. No, you need to have only panel data. You cannot get anything from cross-sectional data. I'm having a lot of these debates. But the combined insights from single data studies, multi-data studies, you can combine all of these, can be beneficial. So let me just leave you with this last statement there, which was picked up from the article that I wrote in 2022. And with that, I will end my presentation, and I look forward to comments, thoughts, questions. What's the situation in India? Look forward to any thoughts you have.
Sir, one question is related to the data collection for the activity-based trips. So, for example, most of the travel behavior survey, if you see the NSTA survey, they have collected about 1 day trip data. But if we see the realistic commute experience of a person, for example, I may be very stressed going to office. So I may have some different mode, but in the evening commute, I am relaxed now. I want some enjoyment. So my mode choice and the path choice may vary. So if we see the within person variation day to day, so and there may be lots of spillover impact. For example, my working condition at the job may have a spillover in my post commute activities. So when we consider these kind of variation within person variation day to day, how to incorporate this in the travel behavior data sets?
I don't have an immediate answer to that. It's a very good question. Again, I would say there's a paper by Katie Asmussen, my former PhD student. We talk about this issue, especially in the context of telework, because telework, we think of telework not necessarily on the basis of am I going to telework today or not, but we think about on a weekly basis how often might I telework. Okay, and many people have flexibility to decide. I have to. I plan to go in three times a week. So, which are the 2 days I'm going to telework? That some people have some flexibility on that. So, yes, your point is very well taken. We had a discussion about this recently in an activity-based modeling conference in Munich in December. I think there's a general sense that we have to go much more toward multi-day surveys. There are obviously some issues with that. Cost is probably the number one thing, and survey response fatigue. But that's not to underplay what you're saying. I think it would be nice to go to having multi-day surveys in the future.
Okay, just one question more. One regarding the choice models, the latent choice models when you estimate. What about if you at the place of latent variables, we include physiological data, for example, their actual stress level rather than derived from the latent demand?
The latent factors that we use in choice models, it's not like they are latent in the sense that they have indicators. The reason why we construct these latent variables is because any indicator you have might not be a perfect measure of the underlying variable. So these latent constructs are not just made up. They are made up from indicators such as, for example, if you're talking about general physical health, you have BMI metrics, you have various, those are indicators. And these latent constructs are based on those indicators, except we are recognizing that those indicators might have measurement errors.
Thank you, sir.
I would start from the end. So, if I'm audible, you made a philosophical point, as you said, about. Sure, I am Dheeraj Zadich. I am academic associate at finance and accounting area. I'm not a researcher per se, but I'm offering my thoughts or asking questions anyway. You made a philosophical point, but it was you said that specifically related to travel. Uh, in when we are doing the data collection and all, but the point that was related to was new technologies that are coming up, and newer technologies come up. So let's say blockchain comes up or AI comes up. A way of thinking is that it used to be the case that university departments created DARPANET and other frontier technologies. Now startups are creating it. So how do they do their research? How do they come up with it? Two ideas would be that they say, don't argue, build. So they build their products and test it in the market rather than doing a survey. So they build it for one person. So call it N equals one sort of research. Make it for one person. If you like it, then there would be other people's and they will adopt it. If your idea is good, it get adopted in the market. Second would be, I don't know how telemedicine is being defined here, but when I think telemedicine, I think medical facility is in my hand. So let's say if I'm wearing a Fitbit, and every day how many steps I have walked over a period of time with from paucity of data. Almost every day, every second, the data of heart rate and all of time, maybe a correlation in terms of health outcomes are going to come up, and then it will define how I'm going to transport and let's say have the land use. So one question I would have is why we are in terms of urban, because when COVID came up, people thought of moving out of cities, and we are seeing everywhere the cost of living crisis and climate in another ways, even especially in India. So would that change how people even live in urban areas, if they live in urban areas? The ideas that are related to creating a center where older people can go, or minorities in US can go, same can be applied to India. So why are we restricting ourselves to a urban construct of how this new development should be adopted? Thank you.
Yeah, let me start with your second question. I have to go back to this paper carefully because I did feel we did include an urban, suburban, rural location indicator. And yes, in rural areas, there are two things that seem to balance themselves. One is in rural areas, getting to a doctor's office is much more difficult to access because they are in a rural area. But from that standpoint, you would think that rural dwellers would take much more to telemedicine. But they don't seem to because of bandwidth issues. And the second thing is, for many rural dwellers, at least in the United States, it's really a social occasion. It's a small community, and they love in-person visits for that reason. So yes, there can be much more of work done, but even in this paper, if you go through carefully, it's on my website, we did distinguish between urban, rural, etc. A little bit more emphasis on the urban because of traffic congestion and land use considerations. What can we do in urban areas? On your first question, I think it's an open one. I don't think it's this or that again. It's not like n equal to 1 versus surveys. I think you could benefit from doing both. And where is that balance? I'm not sure yet. I would say that I'm a little bit skeptical about the build it and they'll come n equal to 1 kind of a concept. I'm a little skeptical about that. A classic example of that, if I understand right, is Ford, which invested millions of dollars in India production plants. Literally about a year back, packed up and left. Okay. And we were thinking in the United States, gee, if only they had come to us, or if they had come to Sandeep, or if they had come to someone else here in India, they would immediately know that in the Indian market, price is the primary driver. Okay. Not all the various other functionalities that they were intending to offer. And it took them quite a bit of time to realize that the Indian vehicle market was pretty saturated by especially Korean-made vehicles. Okay, because those Korean-made vehicles seem to strike the right balance between some level of functionality, but priced at the right point. Okay, so n equal to 1, build it. I invested so much in India, and then I left India, right? So there are cost implications of some of these things that I think we should be careful.
So thank you, Professor. This is very nice talk. Like myself, Vijay, and I'm postdoctoral research associate in Digital Transformation Center here. And I have basic questions like human behavior or the behavioral economics. When we will see in that perspective, the human behavior is like more comfortable with the physical, see that and interact with the persons or the doctor. Then he feel the safe and he get the medicines. That is the different aspect. Or like when we will see that paper in the behavioral science perspective, that is the different narrative. And second one is that in the health sector, the time is very important factor. If someone is here like need to immediate the medicine or the immediate anything he wants immediately, then how he can manage these things. And like medicine or the health factor is not based on the pre-planned. If we have need instant, then how he or she can manage instantly through the telemedicines? Is there any like application or the solution for that?
I think some medical providers and insurance companies are actually trying to play on that instantaneous consultation. It's quite difficult in the US to get, I have a back issue. I want to see a back specialist tomorrow. It's quite difficult. Okay. And that's where sometimes telemedicine can help, because you do have, at least among certain providers, the ability to talk to a back specialist immediately. Right. On your first comment, I would really turn that around to Preeta. I'm intrigued by this behavioral science center that's happening over here at IIM. And by the way, a lot of what I do is about human behavior. I'm just applying it to transportation and to land use. But at the core, we are trying to use some theories, some econometric techniques to tease out how our human brain thinks. Not that we are wonderfully successful, but we at least want to try to get some kind of a clear, systematic way to get toward that. So I think your first comment is a very broad one. And I think it's going to be an interesting time, especially with all the uncertainties related to technologies. Preeta, you might have some more to add to that, but I think it's a very open question.
I mean, we can talk later about the kind of work that I do with respect to behavior. But I mean, he draws out something very important about, how in-person is different from I haven't directly worked in that specifically, but
I wonder if that can be quantified at least in terms of health outcomes. So let's say if the placebo works or doesn't work, because in person is either going to work or doesn't work. What are the health outcomes? So they don't come from travel studies, but maybe health literature would look at the health outcomes of telemedicine and tell us what we should be doing.
Yeah. I think once again, the issue there is we have to be very careful about self-selection, right? I think I am pretty sure that all the telemedicine thing, it doesn't work, let's say, right? That's why I'm going to my in-person, and I go with that idea and thought, and that itself can act as a facilitator for why I'm adopting or even improve my health just by doing that. So I think some of those issues are tricky to disentangle. What is, if there's a label, I think it's an oxymoron, true causality. Okay, at least trying to move toward that. What is causing what? Can we try to tease that out better than what we have been doing today? I think that's a huge question. That's where some of the techniques that we have developed might be able to help. But I think we just need to be careful about that too.
So one of
they've looked at all these RCTs where they are randomized between having access only to an AI tool, a doctor, or a combination of the two. And I think mostly people have liked some human touch. So this is what I roughly remember that, and there've been multiple studies on this. I think both with the physician who's assisted by an AI tool, physician alone, AI tool alone. Then, they were looking at weight loss also, which our colleague from marketing was doing. I'm forgetting his name right now. But they were looking at, you are trying to reduce weight. Does it help you to just be on the app, have an app with a human or interact with the human monitor or combination? And I think mostly it was never purely, at least there was a desire for human connect. So all of this was not really telling. All of this was
Yeah.
all sort of in the tele phase, but I mean the physical aspect was not there, but it was human and
Yeah. I mean, on the surface, I can understand. I'm a very touchy-feely person. And I think possibly some kind of a hybrid where I am able to do tele sometimes, but also have regular check-ins with that person, I think might be a good way to go. Yeah, a lot of the results over here too, as you get older, and I would like to characterize myself as still being young, though my body sometimes creaks up and says, "You're having back pain. Come on, what?" And I'm like, but I'm getting there a little bit. And there's a lot of literature that suggests this is just an anecdote. When I was growing up, we were in a joint family. And it's a very traditional family. My dad would listen to his mom. That's it, period. My dad's mom was queen of the home. My mom had no say, absolutely no say in the home. But I recall, I'll connect this to what we are talking about. It was a time when TV just came into being in our homes. And my mom was an unbelievable MGR buff. Any of you know MG Ramachandran? Have you heard the name MG Ramachandran? He ruled the Tamil world, the cinema, for years. When MGR would cry on the screen, my mom would have tears in her eyes. That was the connection she had. And so this movie is going on. And suddenly, my grandfather needs to have his food. This is where I was trying to say. As we get older, we get very fixated in terms of what we do, what we have done in the past. It lends structure to our life. Okay. So that's one of the reasons why the literature says it's much more difficult to change behaviors as we get older, because retaining what we have done in the past is our form of feeling young or feeling in control when our body parts seem to be giving out, right? So my grandfather had to have his dinner at this particular time. And it so happened that my mom was the only one who should serve him. Okay. And I remember my mom's angst when she had to leave this MGR and go and serve my grandfather his food, right? What I'm trying to say is a lot of the old individuals, I think they tend not to adopt any tele, not simply because they are not that tech savvy. That's part of the reason. But this is what I have done all my life. You look at any technology, older people are more reluctant to accept. There are exceptions, but in general, right? Autonomous vehicles, self-driving cars, old people will generally say, I don't want it. I don't want it. Driving gives me my youth. It gives me control. So yes, as Preeta was saying, these things, behaviors, tangible, to go to the doctor's office. No logic. No logic. It's simply, I go to the doctor's office, whether I get something or not, I feel I've gained something. But that's my mindset right off. So I don't know how we can tease out some of these mindset issues from, and this is where I think a lot of marketing policies can also come into play. Why are people, so it's not only adoption, but also understanding why. Okay, probing into those questions, I think gives us a little bit more insight on how we might be able to potentially change things, or at least say, older people in general, they are going to be like this. They are going to want in person. And how can we facilitate that better? So it's just a long answer to any question that was asked or comment, but yeah, these are all part of human behavior. It's fascinating and so much more to be learned.
I'm not sure what was the question in there.
So put it this way, women are about 10% more likely than men to adopt that behavior or to provide that as a reason. Now, this, by the way, not simply descriptive statistics. This, after we did all the modeling, we translated those models to what we call elasticities of some kind. So it's controlling for a variety of other factors.
So a couple of very quick points. Of course, fascinating study, and I think it has huge implications for India as well. I mean, somebody mentioned about not only urban health but also rural healthcare. But I have a couple of points. The first is maybe it's not here in the data, but could be next steps. For example, you talk about adopting telemedicine, but is it also possible that the level of healthcare sought could be different, right? I mean, seeking telemedicine for a common cough and cold or primary care versus going to a specialist or seeking specialist care, as you mentioned. And there could be variations across income groups, or even within a certain income group, there could be those with certain attitudes that would prefer to directly go towards a specialist care versus those that are more reluctant. However, from a convenience perspective, they would seek primary care. From personal experience, I do use telemedicine and it helps. I mean, maybe even at 10 o'clock, right, the kid has a common cold and there would be someone to prescribe a particular medicine, right? So, but would I be comfortable in seeking specialist care? I don't know. So is that something that is available in the data, or is there something that could be done? Yeah.
Very nice, excuse me, interesting question. And for those of you who are studying in this area, what better place than to be in IMA? Because Sandeep is bringing up the bigger issue. Everything is so connected today. This whole notion of interdisciplinarity, as cliche as it might seem, is so relevant to everything we do today. Transportation is quality of life. Okay, accessibility is quality of life. Even if we are able to do everything online, being able to access some of the activities we like to access outside the home is important for our quality of life, right? So to answer your question, Sandeep, this was not asked. This was a little bit more of a transportation survey. There is a journal that we have started publishing a little bit more in. It's called the Journal of Transportation and Health, JTEH, right? So clear realization that some of the issues that you're raising must be addressed much more so than what we have. And I think it's important from, not just from the health issue, but also from a transportation issue, because as you said, whether I adopt or not adopt might be very specific to a specific situation. So yes, a lot of work possible here.
Thank you. Online.
So we have a couple of online questions. So Gopi Krishna Panikar, one of our online attendees, he wants to know, did the year-on-year changes in reimbursement in Medicaid plans across states influence adoption in low-income groups?
We have not looked at it at all. That's the open question. I just don't have an answer to that.
All right, same person. Could you please clarify the proportion of respondents who were 65 years and above and were having Medicare coverage?
And who were having medical coverage.
Yes.
All the people included in the study had medical coverage. And I don't have, it's there in the paper, but my recollection is that about a good size, about 25 to 30% were 60 or 65 and above.
Another question is, was cost of care via telemedicine the same as that for inpatient visit?
Yes. The simple answer is yes. It's based on copay of insurance, And most insurance providers charge about the same, whether it's online or whether it's in person.
So last question, can secondary data of consulting firms be helpful to gain insights?
Secondary data of?
Consulting firms.
I'm not sure what kind of consulting firms, but in general, any good data is always welcome.
Thank you, sir.
Just a comment. So you said that, telemedicine might reduce the need to travel. But I was also thinking, we have gotten, the advice from the doctor, but now we need medicine. I am not going out, even for a prescription. Then I might order, the medicines and
Totally. Yeah. I think I should have worded that perhaps a little bit more carefully. My sense is, and again, we haven't looked at this carefully yet because we don't have the travel data. My sense is that telemedicine will not engender as many out-of-home trips as my tele-shopping or as my telework. That's my general guess, though it's quite possible that because of the time saved from telemedicine, I suddenly feel like I have more time and I spend that time in more out-of-home activities. It's a possibility. But I just feel that telemedicine has much more of the opportunity or possibility of reducing travel more than tele-shopping and telework. Well, wonderful to catch up with you all. And I look forward to meeting up with some of you. Have fun, folks. Really good time to be in the scholarly area.
Thank you so much. Again, excellent study. And I think this is, we got some good questions, and thanks for patiently responding to all of them. We have a small memento for you. Just thank you.